Today we are going to be talking about Chapter 16, Emergency Situations. This is the second time I'm recording the slideshow today because apparently the narration didn't work on the last one. So good news for you guys, it probably will be more concise the second time through. So we will go over respiratory emergencies, allergic reactions, and cardiac arrest. Also, while we do this, we will talk about some drugs given, the role that you guys will have to help. So first up, let's talk about terminology. Anaphylaxis is an unusual or exaggerated allergic reaction of an organism to a foreign protein or other substance. Asystole is cardiac standstill or arrest, also means, the absence of heartbeat. Bradycardia and bronchospasms are both complications that relate to anesthesia care. Bradycardia is a slow heartbeat, less than 60 beats per minute. Bronchospasm, this is the involuntary contraction of the smooth muscle of the bronchi, which causes impaired breathing. Diaphoresis is a clinical sign of malignant hyperthermia, and this is perspiration, especially profuse perspiration. Hemoglobinuria is the presence of free hemoglobin in the urine. This is characterized in a hemolytic transfusion reaction, and you can tell that this is going on because the urine will be like a cola color. Pyrexia is a fever or febrile condition. It's often believed to be an early indicator of malignant hyperthermia, but it's actually a late sign. Tachycardia is abnormally rapid heart rate, more than 100 beats per minute. Tachypnea are very rapid respirations, greater than 30 per minute, and both of these are early clinical signs of malignant hyperthermia that we'll talk about. Urticaria are hives or raised skin patches, and these can be a sign of an allergic reaction. So first off, we're going to start by talking about emergency situations associated with anesthesia. So respiratory emergencies, these will include bronchospasm, anaphylaxis, and laryngospasm. You can also have cardiac arrest related to anesthesia, and then malignant hyperthermia or MH as well. Both of those are going to be a lot more rare, but they're important to understand. So it's going to be important that you guys have a thorough knowledge of the medications that are often used in these emergent situations. So respiratory emergencies can happen for a number of reasons. They can be from swelling from trauma or inflammation caused by allergic reactions, also bronchospasm and laryngospasm. We'll talk more about the bronchospasm and laryngospasm, but I do want you guys to notice this picture here. The bottom left one is a laryngospasm. So you can see on the left, the vocal cords are open, and this is just during normal air inspiration. And then during a laryngospasm, you get a sudden closure where everything just clamps down, and you can see how that would block the airway. Bronchospasms, picture on the right, you'll see the left tubular structure is a normal airway. And then that middle one, you can see an asthmatic airway. So it's a lot more inflamed and it has less area for air to move through. And then during an asthma attack, the picture on the right, you can see how it really clamps down and how that bronchospasm limits how much air is going to move through. So allergic reactions, signs of these can occur anywhere from 2 to 20 minutes after something triggers it and can last up to 36 hours. They can be anywhere from mild, and that's going to include skin redness, hives, and raised skin patches. They can also include serious reactions that are going to be cardiovascular and respiratory emergencies. Specifically under this category is anaphylaxis, where somebody can't breathe. So if somebody gets these early signs, the anesthesiologist is going to remove the potential triggers that could be causing it and see if it helps to resolve the situation on its own. So in case that the conservative treatment isn't effective, the allergic reaction can quickly progress to anaphylaxis. So in order to prevent that from happening, they might do a couple different things here. They might administer two different types of histamines to counteract that allergic histamine release, and those may include H1 or H2 receptor antagonist. And then as well, they're going to give the patient Benadryl. That's an over-the-counter medication that's taken orally for mild allergies, but we can also give it in surgery to help counteract those allergic reactions. In the instance that the allergic reaction is not stopped by the more conservative treatments, then it may progress to anaphylaxis. This is a complete cardiovascular collapse. It's going to happen very rapidly and can also include cardiac and respiratory arrest. So basically, heart and lungs may stop working completely. It's important to remember, epinephrine is the first line of treatment in anaphylaxis. It's the first thing they're going to give, and it's a potent vasoconstrictor. They may also give corticosteroids in surgery to help with this as well. You can see on table 16.1 that's in your book as well, summary of drugs used for respiratory emergencies if you want to look a little bit more at those. Like I said, the first one on here, epinephrine, is going to be the most important one for you guys to be aware of. Another thing that can happen in surgery is an allergic reaction, including blood. So this would be called transfusion or hemolytic reaction. It is infrequent, but it's important that you guys know what it is. It's going to happen when incompatible blood or blood products are administered to a patient. So, we've talked about blood typing before and how it's important to give the same blood type to patients. Sometimes you still may get reactions. These are going to be characterized by hypertension, hemoglobinuria, anuria, fever, and disseminated intravascular coagulopathy, or DIC. So the first thing you want to do in this instance is to discontinue blood products. There are three types of transfusion reactions. Febrile non-hemolytic reaction is caused by antibodies binding to donor white blood cells or platelets. This is rarely going to be seen in surgery. There's also allergic and hemolytic reactions. So bronchospasm, this is going to be impaired breathing from contraction and inflammation of the bronchi. You can think back to that picture I showed you earlier. Signs of this are going to be wheezing, prolonged exhalation, decreased breath sounds, decreased O2 saturation, increased airway pressures during positive pressure ventilation, and hypotension. So when the anesthesiologist is presented with these signs, they're going to first look for mechanical causes. So they might make sure that the anesthesia machine is hooked up correctly, all the tubes are in place. They might also then in turn look at the patient, make sure nothing's blocking their airway that they can see. And then if they don't see any of those causes, they'd move on and look at treating it with drugs. So the first thing, they may give either beta adrenergic agonist or anticholinergics. These will include albuterol, terbutaline, and epinephrine as far as the beta adrenergic agonists go. And for anticholinergics, atropine and ipratropium. If the bronchospasm still persists, corticosteroids like hydrocortisone or methylprednisolone may be delivered in an aerosolized form, but usually they're going to be given through an IV. That's the quickest way to get something into the patient and get it working quickly. So again, you can see how the bronchiole clamps down and narrows that opening. Laryngospasm is involuntary constriction of the vocal cords. It can result in partial or complete closure. This typically, if it's going to happen, will occur either intubation or shortly after extubation. So either when that breathing tube's going in or right after it's being pulled out. Patients are most at risk for laryngospasm if they're lightly anesthetized when they're pulling that tube out. And there is a patient population that is more likely to have laryngospasm, and that are children and infants. So a lot of times when we've done surgery on a pediatric patient, especially like tonsillectomies, something like that, Anesthesia is very careful to make sure the patient isn't going to have a laryngospasm because it is an emergency situation. So if they notice that the patient is undergoing a laryngospasm, the first thing they're going to do is do a chin lift on that patient, and they'll have that breathing mask over them and do positive airway pressure and hope that that will open up the larynx and get them breathing again. If it doesn't work and resolve, and you see that the oxygen saturation is going down of the patient, they may go ahead and give a dose of a depolarizing muscle relaxant like succinylcholine through the IV. And if you remember from the last chapter, when they are giving succinylcholine, it is a paralytic, so then they're going to have to re-intubate the patient. Atropine may also be administered in pediatric patients to help treat bradycardia that's caused by lack of oxygen. Cardiac arrest is the sudden, unexpected loss of cardiac function, breathing, and consciousness. You may have heard it called a code blue, or in surgery, we're more likely to call it a cardiac arrest or just a code. This can occur at any time before, during, or after an anesthetic is given. So depending what you guys are doing during the time that this happens, your role is going to vary a little bit, and we'll talk about that in more detail. So before you guys even start your clinicals as a surg tech student, you will have to be certified in BLS or basic life support through the American Heart Association if you aren't already. So this is going to teach you, how to perform CPR, and this will translate over to the operating room. It's going to be a very important skill. Your role is going to vary as a surg tech and what you're going to be doing in these code situations. So it depends when it occurs. Is this before the procedure starts or after, or is it taking place during? Who's present? Is there a lot of help there? Is it short staffed because it's a night or off shift? And then what's everybody else doing during this time? So we'll talk a little bit about what your role would be in all of these situations. As a scrub, so you're scrubbed in with the surgeon and you're helping him during surgery. If the patient codes at this point while you're operating, you need to stay scrubbed in. It's important that you're still helping the surgeon and everybody else in the room can run to get things and start performing compressions. Because your important role is to stay sterile. Now, if you are just an assistant, so there's somebody else that's scrubbed in with you and you're just kind of assisting and holding retractors, if you are able, you're going to want to break scrub and be extra hands for people in the room. So if you need to go get the code cart, you could do that, help do compressions, all of those things. That would be a good role for you. The same situation, if you are helping the circulator, you're a second circulator, you're going to be able to run to get things and help with compressions. The registered nurse in the room during this time, they're going to be able to help give medications as directed by the anesthesiologist, and they can also act as recorder to write down the times, doses, and what medications are given to that patient. You may have other people in the room. They're going to have some different duties. It's just important to know as a surg tech, you may not give medications to the patient. You can do compressions or be a runner, but you may not give medications. That's something reserved for a physician or a registered nurse. Keep in mind, sometimes these things will happen before surgery even starts. Maybe you're scrubbed in getting your sterile field ready and the patient codes. Depending how many people are around, if there's a lot of people to help, you may go ahead and just stay scrubbed in and protect your sterile table so nobody contaminates it unless they need your help and ask for that. And also, if there's not a lot of people because it's an off shift, then you're probably going to need to break scrub and help be hands-on with that patient. You can see here a crash cart. We also refer to it as a code cart. It's going to be one of the first things you need to grab in a cardiac arrest situation. Somebody will run for this and bring it in. It's going to have medications, supplies, maybe a backboard to put under the patient for compressions, defibrillator, all of those things that you would need in a code situation will be included on this cart. And then you can see on table 16.2 the cardiac resuscitation medications. Depending on um, what is going on with the patient, it's going to require different drugs. Again, though, epinephrine is often the first line of pharmacological treatment, so it's going to be the first thing that's given. Keep in mind, they may also give vasopressin and amiodarone for cardiac arrest. For bradycardia, that's slow heart rate, epinephrine, atropine, and dopamine. And then if the patient has tachycardia, that rapid heartbeat, it will be adenosine, amiodarone, and diltiazem. I don't think I said that right. You get the picture. And then VFib and VTAC, epinephrine, and vasopressin. So all kinds of different things here, but you can see epinephrine is basically indicated in all these cases except for tachycardia. So asystole is the absence of a heartbeat. You can see that on the EKG strip here, just the flat line. Bradycardia is slow heart rate, and tachycardia is rapid heart rate. We're going to talk a little bit about the different cardiovascular drugs that are listed here, and I'll go in a little bit more detail on the next pages. Again, don't get too caught up in these and the details because I just want you to have a general idea that they exist, and any specifics will be listed on your study guide if you need to know them for the exam. Adrenergic agonist. So these are also called sympathomimetics. These mimic the effects of epinephrine and norepinephrine. Remember back to med-term agonist, these cause a response. So they're going to help the body to do something. In the case of dopamine, it increases blood pressure and cardiac output to help treat bradycardia. Phenylephrine, this treats arrhythmias and hypotension. It causes peripheral vasoconstriction. Dobutamine helps with cardiac failure and hypotension. Isoproterenol, I don't think I said that right either, I'm sorry, hydrochloride. This increases the rate and force of myocardial contractions, also treats bradyarrhythmias, and it's a bronchodilator. Norepinephrine is a potent vasoconstrictor used to increase blood pressure, and albuterol and terbutaline treat bronchospasm. Adrenergic antagonists, these are also called sympatholytics. These prevent a response. Antagonist prevents a response. So these block the effects of epinephrine and norepinephrine. More specifically, you may hear them called beta-adrenergic antagonist or referred to as beta blockers. These are going to include atenolol, metoprolol, labetalol. They will slow the heart rate and they treat tachyarrhythmias and hypertension. Cholinergic agonist and antagonist. These are not used in the treatment of cardiac conditions. So when you're thinking about these, they block the effects of the vagus nerve on the SA node of the heart. Remember back, we talked about this before. The vagal nerve helps to slow the heart rate. So they block that. Atropine is going to help treat bradycardia and increase the heart rate when needed. And you remember how we talked about the vagal response, where it slows the heart rate down from stimulus like stretching the peritoneum during a laparotomy, traction on the eye muscles, cervical traction, all of those things can cause a vagal response. So this helps to prevent it. Recall that this also helps to dry secretions. So it's good when you are also intubating patients, then it blocks kind of like all of that excess saliva in the mouth so you can see better. Antiarrhythmic agents, so these are just going to be able to treat some different arrhythmias with the heart. Class 1, these treat VFib and VTAC. Also, these have been kind of replaced by amiodarone, which is a class 3 agent. Class 2, the beta blockers treat tachyarrhythmias. Class 3, potassium channel blockers. And class 4 are the calcium channel blockers that are used for diagnosis and treatment of SVT or supraventricular tachycardia. So basically, these all just prevent or treat irregularities in the force or rhythm of the heart. Vasodilators, inotropes, and vasopressors. So vasodilators, these are agents that relax smooth muscle cells and blood vessel walls. They decrease blood pressure and it's a less restricted blood flow. Inotropes and or vasopressors increase blood pressure. Um, Inotropes do this by increasing the force of cardiac muscle contraction, which therefore helps blood pressure to increase. And vasopressors cause vasoconstriction to increase the blood pressure. So the normal artery in this picture is in the middle, and then you can see a dilated artery there on the left that's been given a vasodilator, so it opens up and it allows that blood to flow through less restricted, I guess you'd say. And then the one on the right, this is where it's a little more constricted artery. They've been given a vasopressor, so it causes that artery to constrict down and it'll increase blood pressure. Next up, we will talk about malignant hyperthermia, talk about some signs of this and course of treatment. Malignant hyperthermia, or MH, is a rare but life-threatening reaction. It's triggered in susceptible individuals by certain anesthetic agents. Once it's been triggered, it can be fatal in as little as 15 minutes, so it's really important to diagnose it quickly and treat it very quickly. If it's not treated, mortality rate is 80%. When we're talking about triggering agents of MH, these are going to be succinylcholine, so remember that as a muscle relaxant, all inhaled agents except nitrous oxide, and some antipsychotics. For this disease to occur, both the trigger and the susceptibility must be present, so you have to have this in your DNA basically to be affected by these triggering agents. It is an inherited muscle condition, so it causes a hypermetabolic state in the patients exposed to the triggers. When the triggering agents are administered, the patient's going to have massive amounts of calcium accumulate in the muscle cells, which is going to cause a sustained contraction. And then eventually the cell metabolism is going to continue at an increased rate, and it's going to cause heat production. There's a depletion of oxygen, which causes acidosis and muscle cell breakdown. So then myoglobin is going to release into the blood and clog up the kidneys. So some signs of MH, we'll start with these. The earliest sign of MH is an increase in end-tidal CO2. So when they're breathing out, you're going to see that number get higher and higher, that they're breathing off more carbon dioxide. This can increase for other reasons besides MH, but once they rule out everything else as being a possible cause, they're probably going to alert the staff that it may be an MH crisis at hand. Other early signs can include tachycardia and tachypnea, which is fast breathing. So like I mentioned, the earliest sign is going to be increased in end-tidal CO2, and then tachycardia is also an early sign. So these conditions can have other causes, but when you combine them with other signs, it's kind of like a classic presentation of MH. Keep in mind too that these signs can be present right after induction or may not appear until several hours later. Tachypnea, that rapid breathing, is another early sign. It's kind of believed to be the body's effort to get rid of excess CO2. And then also muscle rigidity, especially in the masseter muscle. This is present in about 75% of cases. So some people, it could be normal for them that they're just a little more rigid in the jaw. So the anesthesiologist is going to notice that anyways at intubation. So if there's a change where they didn't have that before but now do, that would be another sign of MH. The patient may also exhibit unstable blood pressure, and arrhythmias can also be presented. Cyanosis is another sign. So obviously if your patient is turning blue, that's not normal. They may first check the ventilator to make sure there's not a mechanical cause with that as well. And diaphoresis is profuse sweating. That's caused by heat buildup in the patient, causing them to sweat profusely. Other late signs may include skin mottling, myoglobinuria, that cola-colored urine we talked about, and hyperkalemia. And late signs. So contrary to kind of popular belief, pyrexia is not an early indicator. It's a late sign of malignant hyperthermia. Patients with MH can die in 15 minutes, so it's really important to adopt the best course of treatment and do it in a really timely fashion. You can see here a malignant hyperthermia cart. Again, it's similar in idea to the code cart. It's going to have all of your medication, supplies, everything in one centralized location. So a runner can go grab this, bring it to the room, and have it close by to help with the emergency. Box 16.3, these are the medications that you'll typically see stocked on that cart. Either dantrolene or Rivanto, sodium bicarb, dextrose 50%, insulin, and calcium chloride 10%. The treatment steps for MH are going to be really easy to remember if you use this acronym. So think of this sentence: how do surgical technologists do it? We're going to talk about each step, but the H stands for hyperventilate, D, dantrolene, S, sodium bicarbonate, T, temperature management, D, diuretics, and I, insulin. So the first step is going to be to hyperventilate the patient with 100% oxygen. This is going to help eliminate excess carbon dioxide in the blood. After this, dantrolene is given. It's a skeletal muscle relaxant. So dantrolene is very hard to reconstitute. You have to reconstitute it with a 60 mLs of sterile water, shake it vigorously, and then it can be given to the patient. But this takes a long time to reconstitute, and it requires a lot of these vials for a patient. If you read about it in your book, it's going to tell you exactly how many you could use. Now, though, in 2014, the FDA approved a new formulation called Ryanodex. This only has to be reconstituted with 5 mLs of sterile water. So it's going to be ready for injection in less than 30 seconds and administered in less than a minute. So you may see this at more facilities just because it's quicker and easier to use. Sodium bicarbonate is the next thing that's given to treat the metabolic acidosis from the high concentrations of lactate in the blood. And then temperature management will be the next thing. They may put ice packs at pulse points on the patient, like the axilla, the neck, the groin, and this is just going to help to attempt to cool the patient rapidly. This will help to prevent brain damage. If the patient has an open incision, they may put some sterile ice in there if we can get that made quickly. Sometimes we also have refrigerated fluids, so they may go ahead and put those in the patient to help cool their core temperature down rapidly. The second to last step is diuretics will be given, like maybe a 20% mannitol or furosemide intravenously, and this is going to help to keep the kidneys working properly. If you remember, I kind of mentioned that the kidneys get clogged up by the myoglobin that's released from the muscles. So by giving these diuretics, it's going to help to keep the kidneys functioning and flush that myoglobin out. The last step is going to be treating them with insulin. This will help to treat the hyperkalemia. So it's going to be really important that you guys know the steps in this so you're prepared, and we'll talk a little bit more in these next slides what that looks like for the surgical technologist. First, and the most important thing, and this is kind of a general overview of everything you're doing, always remain aware of the patient and the environment you're in. If you don't know that something's going wrong with the patient, you're not going to be much help. Know what to look for, especially like I talked about these clinical signs here, and be ready to respond when needed and as the anesthesiologist or physician asks you to. Make sure you're focusing on the patient and the needs of the anesthesiologist in dealing with this crisis. And when this is declared the MH emergency, stop what you're doing and be ready to help. Once MH has been identified, the surgical procedure is going to be stopped. All triggering agents are going to be discontinued. Um, if you are at a point in the procedure where you just cannot stop because you have something wide open that can't be left open, you'll stay and help the surgeon to get to a point where you can stop the procedure. If you have an open belly, you may help put cold irrigation in there or slush, ice, things like that. We have special slush machines. Typically, we use these on open heart procedures and organ procurements. So in big main ORs and facilities like that, they should be available for you. And you might even have somebody there to help you make it since you're going to be busy. So if you are an extra pair of hands during this time, you may break scrub to help get ice, get additional people to come in the room to help, or if there's nobody else available, you may actually help to constitute the dantrolene. So especially on off shifts when there's not a lot of people there, you're on call, it's a night shift, weekend, whatever, you may have to be more hands-on in this situation. As a circulating role, it's going to be a little bit different for you. So you're an extra pair of hands for that nurse. You're going to treat it like a code blue, where you're going to go get the MH cart, call for additional help, and then change the anesthesia machine when the provider's ready. This is going to be important because there is gas buildup in that anesthesia machine. So even though they discontinued the agents, there can be residual gases in there. So when it's time, they may just switch out that whole machine for a new one so you don't have any gases that are residually in there. Typically, if we know we have a patient that has a susceptibility to MH, maybe family history or history themselves, the anesthesiologist will flush that machine with 100% oxygen before the procedure, and typically it's the first case of the day, just so there's no chance that they're getting any of those gases. So here's some additional things in the circulating role that you might be asked to do. You might set up the ice lavage that I talked about, that extra pair of hands. Also, if they don't have a Foley catheter in, they're going to need to have one of those placed in their bladder. And they can also do continuous bladder irrigation with cold saline to help cool them from the inside. They may have a Mallinckrodt catheter placed in the rectum, and they can irrigate that with cold saline as well. And then the abdomen, if it's open, they can use that cold irrigation there. And also, if you are in the circulating role, you may reconstitute dantrolene as well. I do want you to remember too, you guys may not give any drugs. So you're not going to, even though you're reconstituting the dantrolene, you will not be the one to give it. A nurse or a physician needs to do that. But just remember, all of things are happening at once. It's an emergency, but the best thing you can do is be prepared to act as an extra pair of hands, do what you're told to, but don't panic. Keep in mind though, the patient, if they're identified as susceptible to MH, there's not going to be a crisis because we know not to give them trigger agents. So it's going to prevent emergency situation from happening. So as a summary, there are a lot of emergency situations that can arise in surgery. They're going to require your quick thinking and assistance. But the more information you guys have, the more effective you're going to be in this emergency situation. So hopefully you guys don't have any questions. If you do, please message me with them and have a great day.